This is part one of diabetes. We're going to talk about. Um, Everybody's pretty familiar with diabetes. You've now been in clinical a while, so lots of patients are diabetic. You've seen the results. You understand quite a bit of it by now. So diabetes basically is just an abnormal insulin production. We're not making enough insulin, or our body's not utilizing what we make, or it's both of these issues. As you recall from other classes, you need insulin to take glucose into the cells. Insulin takes this glucose in the cells. We need glucose in the cells. That's how the cells feed, basically. That's their nutrition. So diabetes, though, wreaks havoc on the blood vessels. So when you have high sugar content in your serum, it basically destroys blood vessels. So that's the downside of somebody with diabetes. If it was only that we just need insulin and everything would be perfect, we could just have people take insulin and nothing goes wrong. But there's a toll that your body takes because of the diabetes. So diabetes, basically $132 billion a year for different health problems that come about because of diabetes. The most common, obviously, since it is an endocrine problem, is endocrine. It's an endocrine issue. So some of the facts about diabetes: the group that has the highest incidence of diabetes, the group's the American Indians. They have the highest. 73% of adults with diabetes have hypertension. That right there gives you, either you would think everybody that has diabetes has hypertension because of the diabetes, or they have hypertension that causes the diabetes. Well, it's not the hypertension that causes the diabetes. It's because of diabetes they have hypertension, because over a long period of time, high sugar in the vessels lose their contractility. They can't expand, contract, and dilate effectively. Long-term effects of complications of diabetes: blindness. Those vessels, whether it's in your large veins or in the eye, they cause problems. So adult blindness. End-stage renal disease. If someone is in end-stage renal disease, they are on dialysis. So there's 4 stages of renal disease. End stage is number 4. Traumatic, non-traumatic limb amputations. People lose their circulation, damage, so they're going to lose amputation. Heart disease, stroke, those go up because of diabetes. That's another issue. Patients with diabetes have a really difficult time healing. So especially in your lower extremities, if they develop a diabetic ulcer, just because of the diabetes and the circulation, they're going to have a hard time getting oxygen, and it just takes longer to heal. So myth or reality: eating too much sugar causes diabetes. So someone that's diabetic, sometimes they do not know, lots of times they don't know when they come down with it, but diabetes usually has notorious P's. They're called the 3 P's. So because of hyperglycemia, that's when someone realizes they're diabetic because their sugar is way too high. That is going to cause polydipsia, polyuria, and polyphagia. So the 3 P's, classic symptoms of somebody who does not know they're diabetic. So types of diabetes. Everybody knows there's type 1 and type 2. Type 1, you need injections of insulin. Type 2, it's usually managed by diet and medication. There's pre-diabetes, basically, and those are patients that are headed down the road to develop type 2. They don't have it yet because our society is just becoming more obese. People eat more. Type 2 diabetes was always called adult onset diabetes. Well, adolescents and children that are now developing type 2 diabetes, there's something wrong. This is usually not what happens. And now you see it more and more and more. So, they need to not referred to type 2 as adult onset because children are developing type 2. Secondary type diabetes is usually a diabetes that comes on because of other problems. For example, patients with pancreatic cancer or pancreatitis will develop higher blood glucose levels and have to be on insulin until that's managed. Usually it resolves once the disease is gone. So that's a secondary form. It usually goes away. Also, another one is gestational diabetes, which has to do during pregnancy, and that usually resolves as well after the pregnancy. So two kinds that are not permanent, but they're caused by some other reason. So there's something out there called the metabolic syndrome. Metabolic syndrome basically, a lot of people have this, and it's basically our lifestyle. It's a Western lifestyle. As countries adapt Western lifestyle, then there's more patients that have metabolic syndrome. So the standard characteristics of this: central obesity, sedentary lifestyle, westernized lifestyle. So a lot of sitting, no exercise, central obesity meaning around the waist, and fast foods, a lot more starches in their diet, bigger portions. This all is part of the metabolic syndrome. So, signs of this, basically, those are the risk factors. The signs: you're going to have insulin resistance, you have elevated insulin levels, or elevated insulin levels, you're having to produce more insulin. You have high levels of triglyceride, decreased levels of HDL. HDL is the good lipoprotein. LDLs, the bad lipoprotein, and an increase of hypertension. So almost all these are caused, or they would go away by more exercise, losing weight, watching your diet. So type 2 diabetes, let's talk with that one for a few minutes. So 90% of diabetics, it's also called adult onset. I just mentioned that that's becoming a misnomer because children and adolescents are developing type 2 diabetes. Risk factor obviously is being overweight. So if patients would lose weight, they would probably then not have type 2 diabetes. So symptoms: fatigue, visual changes, recurrent infections. You could have symptoms like type 1, but type 2 diabetes, basically all these things. And it still comes down to a high sugar content affecting your metabolism and your eyesight and infections because you have high glucose levels. So the most modest weight loss they have found out is that if a patient loses 5 to 7% of their weight and exercises 30 minutes a day, five times a week, you will lower your risk of developing type 2 diabetes up to 58%. That is a huge amount. We can reduce the cost and the effects on the population just by that thing right there alone. So myth or reality: are carbohydrates bad for diabetes? So different things can cause an increase of our blood glucose. Even if we're not diabetic, these things can happen. Stress causes an increase of diabetes. Illness causes that. Surgery causes that. Medications we take, for example, anybody that's on glucocorticoid steroids have an increase of BGs. Just from being in the hospital and surgery causes increase of BGs. Being ill, stress in the family. So this could be physical stress, emotional stress, anything that people worry about is going to cause an increase of BG. So type 1 diabetes, basically what's happened in the pancreas is we have destruction of your beta cells. Your beta cells in the islets of Langerhans, those are the cells that make your insulin. Those basically stop working, and now that's why someone is diabetic. They're not making enough insulin. Type 2 diabetics make enough insulin, just barely, so it keeps them away from the really horrible problems that type 1 diabetics have in a way. So we're talking like type 2 diabetics do not go into diabetic ketoacidosis. So tests to find out if you're diabetic. Well, here are the three. The first three are what they've done for years: a fasting blood sugar test, um, postprandial blood sugar after you eat, an oral glucose tolerance test. These are all basically testing to see what your body would do after you ingested a lot of sugar, carbs. Um, but the one they use now, which used to just be one they would look at, so the hemoglobin A1C is one that they use now all the time, and that really is used for diagnosis, so you don't see the others as much. So basically, they're going to do two of these tests at two different times, and it should be greater than and equal to 5.7 on the two tests for your A1C. So what this is doing is it's testing how much sugar, what's your sugar content on your red blood cells over the last 20 days. Red blood cells live for about 120 days, so it looks back, it can give you this amount and let you know what the score is, and let you know kind of for the previous 4 months what's your serum glucose been. So insulin, you've all given insulin now. Insulin syringe are basically 1 ml, so 1 ml contains 100 units of insulin. That's why we have an insulin syringe that we use. All insulin that we give, it has an onset, it has a peak action, and it has a duration. So all insulins basically, peak action is different, duration, how long does it last, when does it peak, when does it reduce, and that's how they gauge so people don't become too high and also too low in their serum blood sugars. There's rapid acting, short acting, intermediate, and long acting. So a lot of patients they take some in the morning, but then at night they take a very long acting. So it's it's managed very well. So between eating and snacks, everything is taken care of. So your rapid acting, basically your Listro, Humalog, Aspart, Novolog, those are the two most common ones you see. So they start within 15 to 30 minutes, peak at 30 to 90, and last 3 to 5 hours. Short acting, regular, blood levels, it changes within 30 minutes, not quite as fast as rapid acting, peaks in 2 to 3 hours, and lasts 3 to 6 hours. So Humulin R, so regular, Novolin R, those are all very common. These are usually what you give all the time to the patient when you do a VG 4 times a day, and if it's a little high, you give some of this. So that's usually what the sliding scales are based on. Intermediate acting, Humulin N, so NPH, Lente is another common one. It doesn't really go to work starts 2 to 4 hours, peaks 4 to 10, and lasts 10 to 16. So it's a much longer one. And then the really long acting ones they don't really kick in until 4 to 8 hours after peak is small or flat. So 10 to 30 hours, last 20 to 24 hours. These are really long acting. So what I mean by flat is they don't peak like a big surge like the short acting one. So they go up a little bit, but it's very long. It's like basically a plateau. So it's not like it's using it up a lot, and that's why they last so many hours. So pretty much all insulin is giving sub-Q. It can be given in the IV, but you'll see it in the hospital unless you work in critical care. It's pretty much always sub-Q. Insulin pens, basically, you've used those in clinical. It's just looks like a pen. You dial in the number of units you're giving the patient. You always add 2 to prime the needle. So if it's listed that the patient gets 6 units, you would dial in 8 because 2 will be the priming of the needle. They'll still only get 6, but you put in 2 extra. Insulin pump. Patients wear an insulin pump, so it gives them a constant amount. They can adjust that pump little by little if they need it. So that keeps them pretty much as a straight level. You don't have the highs and lows like you do with people taking insulin sub-Q. The issue with insulin pump is someone has to be very, very, very compliant and checking their blood sugar all the time and doing what they need to do, watching what they eat. So these are very compliant patients. Not everybody should be on an insulin pump. So the goal for insulin is, let's keep the BG between 80 and 100. That's very tight control. It used to be, that's our goal. It used to be they'd say 80 to 120, but they tightened that up. So now that's the perfect place. Intensive insulin protocols, there's a lot out there that some hospitals use. So if patients are on certain floors, they will use certain protocols. It'll say if it's higher or lower, how much you're going to give the patient. These are common in critical care, but also on the floor. Portland protocol is probably the first one that came out. That was one that everybody used. You don't see Portland that much unless you're in the hospital where the doctor invented that. I happen to know I know the hospital, the manager of the critical care unit in a hospital in Portland, and the doctor that developed that, that's where he works. It's kind of funny. It's called Portland because that's where he works. His name is not Portland, so all the doctors around him use other ones, but of course he wants to use his own, so kind of interesting. So diet, glycemic index. If someone's counting their carbs, they want to use a glycemic index. Everything's counted on a scale of 100. So 50 grams of glucose or one piece of white bread is 100, and everything else is basically measured against that scale of 100, so they can count how many, what they need, what they want, and people can really do a really good job with their glycemic index based on the carbohydrates and the starch and the sugars. So somebody that is diabetic, though, you basically want them to have not all carbs and not all fat and protein. So, carbs needs to be the majority of your diet with some fat, saturated fat, total about 7%. So there's some great websites for diabetes. If you look at this diabetic website that has a link right here, it has lots of information that patients can go to. Of course, this isn't going to work right now because I'm recording this. Absolutely. Wouldn't work. Here we go. So diabetes, basically, here's the American Diabetic Association. It has tons of information. What can I eat? How to make healthy food choices? What can I drink? So it gives you a lot of information, opening up these links on information to patients. If you're diabetic, how much does one beer equal? How much should I have? What about all the different things? What can I drink? Great information. Anything somebody's diabetic, anything they need is found on this website. So great teaching tool. So hypoglycemic, if somebody is low blood sugar, hypoglycemic, your symptoms are cold, clammy skin, you have a rapid heartbeat, faint, dizzy, slurred speech. These are the common hypoglycemic symptoms. So if somebody is hypoglycemic, you need to give them something fast. So lots of times something just in their mouth, orange juice, drinking it really quickly, something high sugar. Milk is very good for that as well. If they have access and it's in the hospital, they have an IV, and if they're NPO or if they're on a ventilator, then give them something in their IV. So it's usually syringe at D50. You give half the syringe and you check the blood sugar in 15 minutes and then again in 30 minutes.